Good afternoon. My name is Ahmed Soliman. I'm one of the cardiologists here at Houston Methodist, and I would like to welcome you to the DeBakey CV Live session today, updates in digital CV health. We are going to be talking today about screening using digital tools. We have a very important guest with us today, Dr. Sana Al-Khatib from Duke University. She's a professor of medicine and electrophysiology at Duke University. And she will be talking to us today about tools, about atrial fibrillation, and about tools regarding digital health. The reason we bring this up today is because this summer in the European Society of Cardiology, there's a study, the LOOP study, that was evaluating for screening for atrial fibrillation, which brought up this idea of trying to figure out tools for identification or screening for heart rhythms in cardiovascular disease processes. So I reached out to Dr. Al-Khatib, and she is able to join us today to talk to us about atrial fibrillation and the different tools for digital health for arrhythmias. Before we start real quick, I want to make sure that everybody knows that you could join by text, texting DeBakey to 37607 and send the question in the text message, or go to pollev.com and enter DeBakey and enter your questions at that point. Again, I'd like to introduce you, Dr. Sana Al-Khatib. Very honored for you to join us today. The speaker is yours.
Great, thank you very much, Dr. Soliman. It's my pleasure to be with you today. Hearing an echo, hopefully. Sorry if my voice is not projecting. I feel there's an echo.
Okay, no, we're okay.
All right. Well, thank you very much for the introduction. It's my pleasure to be with you today. And as you heard, I'd like to talk about screening for atrial fibrillation. And before I delve into this important topic, I wanted to share that digital health has become really near and dear to my heart. I've been doing some work on machine learning for the prediction of sudden cardiac death, development of clinical decision support tools that can be embedded in the EMR, and so the remote monitoring, things like that. So I really look forward to the discussion. But here I'm going to focus on screening for atrial fibrillation, which is becoming increasingly important. And here are my disclosures. And as many of us know, atrial fibrillation can cause symptoms. And obviously, a lot of people who have symptoms come to our medical attention because of the symptoms that they're having. However, there are a lot of people out there who do not have symptoms related to atrial fibrillation. And that's what we term either subclinical atrial fibrillation or undiagnosed atrial fibrillation. And so the question is, how can you detect subclinical atrial fibrillation? And so here we show you different modalities, starting with the physical examination to monitors that are prescribed by clinicians, like Holter monitors, event monitors, of course, handheld EKGs. Now patients can actually buy those tools themselves. Those don't need to be prescribed. So there are a lot of consumer products as well that can help us detect atrial fibrillation, including wearable monitors like the watches. Different watches can help us detect atrial fibrillation. And then, of course, we have implantable loop recorders. And for those of us who have, a lot of patients with implantable devices like pacemakers, implantable cardioverter defibrillators, we detect undiagnosed AFib in a significant number of patients. And many times we don't know how to treat those and what threshold to use in terms of a starting treatment. Many people ask, what is the prevalence of undiagnosed atrial fibrillation? And some studies have attempted to address this question. Here I'm going to share with you the results of one study that basically attempted to identify patients with diagnosed atrial fibrillation using ICD-9 codes. So these were claims data. And they used those codes to identify those patients. And patients who have undiagnosed atrial fibrillation, the way they captured those patients was by looking at people who had a stroke and then looking to see, which of those patients had atrial fibrillation diagnosed within 3 months after the stroke diagnosis. And then they measured the annual stroke incidence for patients with non-valvular atrial fibrillation, and they used those numbers to impute the total prevalence of undiagnosed atrial fibrillation. And at least in this particular study, they found that the estimated total U.S. prevalence of atrial fibrillation was 5.33 million, with about 700,000 people having undiagnosed atrial fibrillation. I truly suspect that that is underestimated here. And if you look here at this analysis from the Framingham heart study, they actually attempted to determine what percentage of patients with atrial fibrillation have stroke as their initial manifestation. And they found that of 1,809 patients with incident AFib detected during this time period between 1951 and 2013, 1.7% of patients with AFib had AFib discovered at the time of stroke, and 4.8% of patients with AFib had AFib discovered within a year prior to the stroke diagnosis. So that is an important fact to keep in mind, is that many times the initial manifestation of atrial fibrillation is a stroke. And it is also important to be reminded of the adverse prognosis that asymptomatic AFib can indeed portend. So in this particular study that was done in the UK, they took 5,500 patients with asymptomatic atrial fibrillation. And you'll see here that the crude cumulative incidence of fatal and non-fatal stroke was higher among patients with asymptomatic ambulatory AFib than patients who did not have atrial fibrillation. And a similar trend was seen for all-cause mortality. So we do know that there are quite a few people out there with undiagnosed atrial fibrillation. We also know that undiagnosed atrial fibrillation is associated with worse outcomes. And these findings were also seen in the ASSERT-1 trial. This particular trial looked at patients with implantable devices, pacemakers, defibrillators, and they too found that people who had those arrhythmias detected on their devices but were subclinical episodes, those patients were significantly more likely to develop clinical atrial arrhythmias during follow-up and to have an increased risk of stroke or systemic embolism. So that the data are clear. The other thing to point out is that, and this is a statistic that really it concerns many of us, that when stroke occurs in people with atrial fibrillation, the majority of patients who have a stroke in AFib tend to have a stroke of moderate or high severity. So that is something really to worry about. So what do the guideline documents tell us about screening for atrial fibrillation? Well, if you look at the US-based guideline that came out in 2019, not a lot was mentioned on screening. They had these two recommendations that you see before you. The first one is a class 1 recommendation where they say that in patients with implantable pacemakers, defibrillators, the presence of recorded atrial high rate episodes should prompt further evaluation to document clinically relevant AFib to really inform treatment decisions. And then as a class 2A recommendation, they stated that in patients with cryptogenic stroke, meaning of unclear etiology, in whom external ambulatory monitoring is inconclusive, implantation of a loop recorder is reasonable to optimize detection of silent atrial fibrillation. But that was the extent of it in the US-based guideline. If you look at the ESC guidelines, these guidelines came out in 2016 here, they basically do recommend as a class 1 recommendation, opportunistic screening by pulse taking or doing an ECG rhythm strip in patients older than 65 years of age, and as a class 2B recommendation, telling you that, in most cases don't do it, but in some cases certainly consider doing it. Systematic ECG screening may be considered to detect AFib in patients older than 75 years of age or those at high risk of stroke. And many of you may be familiar with this document that the USPSTF published in JAMA of 2018, where they actually conducted a comprehensive review of the literature to determine if they can make a recommendation related to screening people for atrial fibrillation. But after this long exercise, they couldn't recommend it. They basically concluded that there was inadequate evidence to assess whether screening with ECG identifies older adults with previously undiagnosed AFib, and whether that is indeed more effective than usual care. What I do like about that document is the different research needs that they highlighted, where they said, definitely we need randomized trials, enrolling asymptomatic persons that directly compare screening with usual care, and that both assess both health outcomes and harms. And they also said that although the evidence review for this recommendation statement focused on screening with ECG, that's what they focused on, they acknowledge that there are newer technologies capable of assessing rhythm, and as those need also to be assessed as potential screening strategies. And they also concluded that as ECG and other technologies are used that are able to detect shorter episodes of arrhythmia, really trying to understand the stroke risk associated with brief episodes of subclinical AFib and the potential benefit of anticoagulation therapy is another important research need. So stated differently, we definitely have clear data that undiagnosed AFib is associated with an increased risk of stroke or systemic thromboembolism. But future research should investigate whether treating undiagnosed AFib improves patient outcomes, and I will share a couple of studies with you on that. And there is indeed a need to understand whether AFib burden should be a factor in deciding whether or not to treat. And if so, what burden should prompt treatment? What is that magic threshold above which we should treat patients with diagnosed atrial fibrillation? And I do want to share with you the names of many studies that are either ongoing or have just been published related to AF screening. So this is an area that many are studying. And we will see more and more data, which is fantastic for the field, fantastic for our patients. So definitely stay tuned. I do want to tackle the loop study. As Dr. Soliman mentioned, this study was presented at the European Society Congress meeting this summer, and the manuscript itself was just published 3 days ago in the Lancet. So in the loop study, they actually focused on patients with no known atrial fibrillation who were between 70 and 90 years of age. And they had to have at least one other risk factor for atrial fibrillation, for stroke. There you go. They randomized those patients to an ILR, that's the implantable loop recorder arm, and treatment with an oral anticoagulant if they detected atrial fibrillation that at least lasted for 6 minutes and to usual care. And you'll see here that 1,501 patients were in the ILR arm, and the majority of the patients, namely 4,503 patients, were randomized to be in the usual care arm. And in fact, as you see here, more than 6,200 individuals were screened for inclusion, and this is how they came up with these numbers, basically. The primary outcome of the trial was time to the first of one of the components of the combined primary endpoint, which was time to adjudicated stroke or systemic arterial embolism. So what did they find? First, the duration of follow-up was long. So during a median follow-up of about 65 months, AF was diagnosed in 1,027 participants. So that basically resulted in 32% of patients in the ILR group versus a 12% of patients in the control group who had atrial fibrillation diagnosed. So certainly far more patients in the ILR group were diagnosed with atrial fibrillation. And then if you look at the rate of use of oral anticoagulation, obviously, as you can imagine, people who were diagnosed with atrial fibrillation, many of them were started on oral anticoagulation. So 445 in the ILR group were initiated on an oral anticoagulant versus 13.1% in the control group. However, the primary outcome was not significantly different between the two arms. So the primary outcome occurred in 318 participants, mostly strokes, and 67 in the ILR group had a primary endpoint versus 251 in the control group had one of the primary outcomes. And here the hazard ratio was 0.8, so heading in the right direction, so to speak, in terms of the ILR group being superior, but the difference was not statistically significant, as you see here, based on this p-value of 0.11. And so I'm sure we're going to be discussing this more, but my initial thoughts are, is it possible that the trial ended up not having enough statistical power to show a difference? Or did they actually have statistical power that was good enough, but they did not find a difference, maybe because of the AF duration that they used for treatment? As I mentioned earlier, the AF had to last for at least 6 minutes, but 6 minutes is actually such a short period of time. Like many of us would say, we may not actually treat somebody who has AFib for 6 minutes with an oral anticoagulant, except perhaps for patients with cryptogenic stroke, many of us would, but short of that, many of us probably wouldn't treat those patients with an oral anticoagulant. So that may indeed account for those findings. I also want to bring to your attention the stroke stop study, which is also very relevant to this discussion. And this study was published in the same issue of the Lancet. Again, it just came out 3 days ago. And in this study, they targeted people who were 75 to 76 years of age, who were residing in 2 specific regions in Sweden. They randomized those patients to a strategy where they were invited for screening or to a control strategy. And participants without a history of AFib were then asked to record intermittent ECGs for 14 days. Treatment with an oral anticoagulant was offered if AFib was detected, and follow-up was for a minimum of 5 years. The primary outcome here was a combined endpoint of ischemic or hemorrhagic stroke, systemic embolism, bleeding leading to hospitalization, and all-cause death. So what did they find? A total of more than 28,000 individuals were assessed for eligibility and randomly assigned to be invited to screening or the control group. They applied some exclusions here, as you can see. But of those invited to a strategy of screening, 7,165 or 51% participated. And then they found that after a median follow-up of 6.9 years, again, the duration of the trial was long, significantly fewer primary endpoint events occurred in the intervention group than in the control group. So really interesting finding. These findings don't align with the results of the LOOP study, but it's important to keep the inclusion and the exclusion criteria in mind in those studies, the monitoring strategy, as well as the duration of follow-up. And here I'd like to make you aware of a paper that we published when I share it here with you to make you aware of it. If you haven't seen it, I encourage you to look at it. It's research priorities in atrial fibrillation screening. And this was an NHLBI virtual workshop that I had the pleasure and privilege of co-leading with several of my colleagues, including the first author, Dr. Benjamin. And here we really provide not just a quick overview of the field of screening for atrial fibrillation, but we identified research priorities in this area. Happy to take any questions you may have about that. And then finally, want to conclude before we start the discussion by stating that although there are definitive data that subclinical AFib is associated with an increased risk of stroke and systemic embolism, to date, there are inconclusive data on whether treating subclinical AFib improves outcomes. But as you saw, we have an abundance of studies looking at this question. And I am confident that we will be able to find more definitive results. Data are lacking on what burden of AFib should prompt treatment. And as you saw, the guidelines that I shared with you really reflect this paucity of data. And as I mentioned, more studies are underway that hopefully should inform our clinical practice and future guidelines. Thank you very much for your attention.
Thank you very much, Dr. Al-Khatib. That was very informative. We actually got a few questions already. But beforehand, regarding the LOOP study, I know we kind of go back and forth on the LOOP study because to me, me personally, and this is why I brought this up, is because, I've diagnosed AFib through Apple Watches or through Cardia and started patients on anticoagulation because you've been diagnosed with atrial fibrillation. According to the CHADS VAS score, then you should be anticoagulated, and this is what I discuss with patients. One of the things I was thinking of when I did from the ESC when they initially presented it was, while the inclusion criteria was the 6 minute of atrial fibrillation, but they have an implantable loop recorder in place. Why can't you get the data, let's say for a more longer period of time, of the overall burden? Just like when we put a patch monitor on a patient and we get a PVC burden to make a decision about treatment, you have an implantable loop recorder there, and if I remember correctly, it doesn't say how long they kept it or if they removed it, but in theory, you still have data that you can still obtain.
I completely agree with you, and I think this will be incredibly important to look at in terms of really delving into the details of the information from the loop recorder in terms of, yes, they required at least 6 minutes, but what actually happened in a real practice. And as a practicing electrophysiologist, I have hundreds of people with implantable loop recorders to focus just on those patients. Now, obviously, a lot of those people, have the ILR for cryptogenic stroke, and there I completely agree with you. Any AFib should prompt treatment unless the patient has, a contraindication. And even now, actually, even if people have contraindications to oral anticoagulants, we can still discuss a Watchman device with them, so on and so forth. So now like these options are increasing. But like even if you look at the other patients, perhaps having some symptoms, palpitations, really high risk of stroke, but they haven't had the stroke yet, haven't documented AFib. As you know, like, first of all, not everything that the device labels as AFib is atrial fibrillation. That's an important message to convey. Yeah. So that's one. Number two, many times, you may find like an episode of atrial fibrillation that lasted for, 2 minutes. But then the patient may go perhaps for several months without having another episode, or perhaps a year without having another episode. Is that enough to start patient on an oral anticoagulant? Yeah. Many people, again, here I'm talking in the absence of a stroke. Is that enough? I mean, many people would say maybe not. And I'm pretty sure you are aware of a few studies that are now looking at the use of oral anticoagulant as needed, meaning when a patient has something that is continuously monitoring them for AFib. And then, once you detect AFib, or they detect AFib maybe with a wearable watch or something like that, maybe that during that time they can take their oral anticoagulant. But once they're out of it, maybe they can go for a period of time without taking it. So is there a room for as needed anticoagulation based on what we're detecting? So a long discussion in terms of like, what is the burden? We do know that we have patients, they have AFib and they continue to have AFib. That's clear cut. But many of our patients fall in the gray zone where we do not know, like they have the short episode that they go for a while without having anything. Is that enough to treat them with an oral anticoagulant indefinitely?
No, I totally agree. And I think when you also think of the patients that tell you, I know when I'm in AFib, and I don't, and I know when it started, I know when it stopped, those you may be a little bit more comfortable saying, well, here is your anticoagulant, and take it when you feel it. If you are very confident that about that. But in these cases for the loop and a stroke stop, for the most part they're asymptomatic or silent AFib. This last month, for example, I've had personally 2 inpatients that came in stroke as the presenting complaint of AFib, and it breaks your heart when that happens, because what if I would have caught this earlier?
Yeah, exactly.
So some of these questions, actually, I think you already addressed, but one of the questions actually goes back to the burden of AFib. We know for the most part PVC burden and when to refer to electrophysiology and when to manage, but AFib burden. So that goes back to the same question of AFib burden. How can we verify the AFib burden, and eventually when we'll be able to figure out when should we treat it?
Yeah, no, that's a great question, and I don't know that the answer is no. I mean, based on all the evidence out there, or the whole literature that I have reviewed to date, I would say that it's not clear. Now, obviously, here's what I would say. That certainly the burden of AFib is one important factor to look at, but I do think that there are other factors that need to be looked at also. Namely, the CHA2DS2-VASc score, as you very nicely said, Dr. Soliman. The CHA2DS2-VASc score is important. Like the higher the CHA2DS2-VASc score, probably the more likely many of us will consider starting someone on an oral anticoagulant, even if their burden is on the low side, right? So that's one thing. Also taking into account the bleeding risk of the patients. If the bleeding risk is very high, perhaps that needs to also be taken into account while counseling the patient about these things. And as you very well know, a lot of this is also a discussion that we have with the patient, because ultimately the patients are the decision makers, and this underlines the importance of, shared decision making, which is very important, where we as physicians will sit with the patients and talk to them about the risk of stroke, the risk of bleeding, the available evidence, understand their preferences. And many of us have had, examples of patients, you give them all this information and they still opt against starting an oral anticoagulant. So it's multifactorial. It's just not just the burden. I do agree that the burden is important, and we still need more data about what burden constitutes meaningful risk where treatment will make a difference. We do not know that, but I agree that these studies will help us address those questions, but also really pulling into this picture other factors.
I'm hoping that the LOOP investigators actually have a continuous, a long-term type of follow-up with the ILR in place, because that actually, I think that might give a window in regards to the idea of how much that burden was on these patients that we started with anticoagulation or not. And on the LOOP study, if I remember correctly, there was actually a higher tendency for bleeding events on the patient that did get anticoagulated. So maybe a Hasblad score or so forth of these patients may also be informative, just like we were saying earlier. So another question is wearables. Wearables the studies that have been done on implantable loop recorders, but we get information from wearables like Apple Watches or Cardia. What do you think the difference would be in regards to treatment? I think what he means is, what do you think the value maybe of the data coming from wearables versus something more prominent like patch monitors or implantable loop recorders or so forth?
Yeah, no, absolutely. That's a great question. And I tell you, like in the circles that I am in, this question comes up very frequently. So I can tell you that I think different people have different approaches. Here's what I would say, because I'm more like, give me the evidence, give me the data. Now, not everybody probably asks for the same level of evidence that some people ask for, okay? So for me, if a patient is using a consumer product, and that, alerted the patient that they have atrial fibrillation. Now, many of these patients send us these tracings. I don't know about your clinic or your practice, but they end up sending us these tracings, and we look at them. And I don't know about you, some of the tracings are very suggestive that is true AFib, and sometimes the tracings are not that helpful in terms of, well, there's a lot of artifact. I'm really not sure if this is AFib or not. I tend to want to validate those findings using a modality that is prescribed. Either like an event monitor, ILR. Again, it all depends on the patient presentation. Why are they using the watch in the first place, or Cardia, for example, in the first place? Now, Cardia, as many of you know, they initially came out with a one lead recording machine, and now they have 3 leads. And so, of course, the more leads you add, the higher the likelihood I get suspect to be able to accurately classify rhythms. So I do think that this field is evolving too. But until I see more data, my approach has been that once I see something that might be AFib or looks like atrial fibrillation, I tend to put people on something that is prescribed to confirm those findings.
Trust but verify.
Exactly.
I get this all the time in my Epic inbox, tracings from Cardia or from the Apple Watch, occasionally with PVCs or just PACs, and it looks very clearly to PACs. But I've had a few that were AFib. And frankly, I calculate their CHA2DS2-VASc score, and then if I am very confident that this is AFib, then we calculate the CHA2DS2-VASc score, and we have that discussion, and usually we start anticoagulation. But I think one of the issues also is that the market of digital wearable tools is growing a lot faster than the medical community is catching up in regards to data. The problem with that is we are going to get bombarded with these either artifacts or possible, good tracings or bad tracings or so forth that we have to address at one point or another. And many are very concerned about doing it medical legally, even saying, I don't think that this is AFib, but if it turns out to be AFib and he does have a stroke the next day or so forth, how do I address that? I think one of the problems is we're going into commercial-based digital tools, but not medically, not medically sound medical tools or digital tools.
Yep. That is an excellent point that you bring up, Dr. Soliman, because as you nicely stated, yes, we are all excited about digital health, but digital health and all these screening methods, all these wearables are moving at such a fast speed, and we need to catch up. And so many of us have actually advocated for professional societies to take this on in terms of, we're providing, even like either expert consensus statement or some guideline document or something that can help practices establish workflows, so to speak, and good clinical practices in terms of how do you address these requests from patients? Yeah. What does that look like? And how do you achieve, efficiencies? How do you make sure that you are accurately diagnosing patients and managing them promptly and hopefully impacting their care and their outcomes in a positive way? And so we continue to advocate for that, many of us, and I'm hopeful that we are going to start seeing more professional societies taking this on in terms of providing guidance, because yes, we need the evidence, but we have patients who started contacting us with these requests, I don't know how many months ago, maybe a few years ago now. And so we really need to catch up. I agree with you there.
Yeah. And that might include much larger and robust trials. And eventually, I think that CMS or government entities would have to also be involved to grade something as a medical level digital tool versus not, because it's very easy to, patients want to know about their health. They want to do steps to take care of their own health. So it's very easy for them to buy devices all over the place. I think they also need to be labeled appropriately. So I think that's an important part. Another question was PPG versus ECG identification of atrial fibrillation. Is it worth it? And I'm assuming this would be more of the, not necessarily the Apple Watch or other watches, EKG tracing versus the PPG tracing that would identify and ask them to check for an EKG to look for atrial fibrillation. Do you think that the PPG on most of these devices would be sufficient?
That's a great question. I'm not so sure. As I said, I am excited to see some modalities making it to the market where you have not just one ECG lead, but a few ECG leads. Because you really want to be able to verify this. And many of us sometimes, even with the prescribed, with our ILR, don't go too far. Even with the implantable loop recorder, sometimes you look at the episode and you're not sure, is it AFib, is it not AFib? I do expect the technology to continue to improve, obviously, but yeah, from my perspective, I feel like the more ECG leads we have, the more likely we are to make a more accurate diagnosis.
No, I completely agree. The PPG sometimes is, especially with the watches, how they are on the wrist. Another question is: have wearables reached their full potential? I think I know the answer to that, but Dr. Khatib.
Yeah, no, I would say no. I don't think so. I think there's far more to do in this space. First of all, in terms of understanding how that may impact patient care, patient outcomes. We still need a lot of data there. The technology is evolving. How much more can we actually do? So no, I don't think that the wearables have achieved their full potential. I honestly feel like we're still at the beginning, even though we have made a lot of progress.
No, I completely agree. I think wearables, I know there's a more recent blood pressure device. I tried it out a few times. You just have to hold it up to your heart and use it, and it's a little bit cumbersome, but officially, technically it's a wearable blood pressure device. In my opinion, I think wearables are a lot more helpful from activity standpoint to show or prove or disprove to patients how much activity they're doing and how they're progressing. We could make an argument also for heart rate and heart rate recovery. I think those are relatively easy things. I have a lot of patients that are really relatively deconditioned that have exaggerated heart rate response to exercise, and 6 to 9 months after kind of conditioning exercises, then you show them how their heart rate is improving at rest and with exercise. But regarding yet more sophisticated items from a health standpoint, I don't think we're there yet.
Yeah, no, I completely agree with that. Of course, as an EP, I mostly focus on the rhythm and the rate, but you're exactly right. Like, digital health, when it comes to these wearables, extends well beyond that. So like you think of, monitoring glucose in diabetics, monitoring the blood pressure, as you mentioned, fitness, giving people even potentially some, opportunity to monitor their food intake if they're trying to lose weight, like with this biofeedback mechanism. So there are a lot of, opportunities, obviously, that extend well beyond rate and rhythm.
Yeah, honestly, in my opinion, I think actually the biggest tool that, or the biggest disease process that we should use digital health for is one of the things that we actually do not do a very good job with, which is hypertension. Yeah. Across the country, we could do much better control of blood pressure using digital tools, but yet, and even there are actually billing codes for it, but practices are not necessarily using it. Again, like we talked about earlier, the culture of using digital tools for chronic management is still not there yet. I think that diabetes, the CGMs, the continuous glucose monitoring, that is growing at a very fast and very good rate. But I don't think blood pressure yet is there. And honestly, that's a very simple thing that we could do and have a significant impact on cardiovascular risk.
Quick question, if I may, Dr. Soliman. What about your thought? What are your thoughts about some of the monitors that determine or assess the sleep quality? Because now, there's so much emphasis on getting enough sleep quality, all of that. Of course, even potentially diagnosing sleep apnea in some people. This is a big deal. Association with the AFib, going back to the topic of our presentation. What are your thoughts?
So I actually got, this was about 1.5 years ago or so, this is my wedding ring, but they had another ring that also monitors your sleep pattern. And I used it for about 6 months. I sometimes try to just get the device myself and try it out before I talk to anybody, because patients come with it. And obviously if I sit there, I'm like, I have no idea what you're talking about. It gave me some nice information, but to be honest with you, I don't know if it is quality information. And then when I tried to look back, and I actually sent to the company trying to get data for where did you get this data from, and try to get, did you get any type of real clinical data? It was mostly their own internal data. So again, we go back to that same point of devices need to be labeled, and they need to be labeled, like you were saying earlier, either through a professional society or frankly through the government. But it is very simple to say, buy a ring, a few $100, and it will tell you about your sleep pattern. You're a non-medical person. You want to find out about your sleep. You want to know about your health. Why don't I just get that? People are hesitant to go to the doctor because they feel, we're going to be a lot more, in regards to more testing or more imaging or stuff like that. So I feel that patients want to get their own devices to find out about their own health, but unfortunately, it's basically open season.
Yeah. No, I get it. Your point about labeling is well taken, because usually the FDA is the entity that labels these products. Professional societies are probably not going to get into the labeling, but they can provide recommendations in terms of good clinical practice, what that looks like, what is the workflow, what is needed. So, I mean, I agree. I think a lot of these, entities have a role to play.
Yeah. So we have another question. Are there any ethical issues with wearables and collection of data? What are your thoughts, Dr. Al-Khatib?
Well, so, if the patient, so I would love to get more information, from this person who asked this question. In terms of ethical, like if the patient is sending you this information, okay, I don't see any, like, for example, HIPAA considerations there. Correct. Or any, like, because they're sending you this information, they want you to weigh in on this. But perhaps if they meant like legal issues, you alluded to that earlier, Dr. Soliman, and I agree with your point totally. Like, at what point do you say, like the clinician is liable? Maybe the patient sent you something and the next day they had a stroke. Are you liable? Like, especially because they used a tool that you didn't even prescribe. I don't think that this is very well studied. I don't know that anybody has really, I personally would say probably not, if you did not prescribe the test or the modality yourself. But I could see things, getting a little bit out of control.
Very true.
And so that's why I kept going back to the point of, please give us some guidance in terms of what we need to set up in our practice to ensure that this is first feasible, doable, we create efficiencies, we're still providing good care. When obviously some patients also may not have realistic expectations. If each patient is sending you, 100 tracings per day, there's no way we can accommodate that volume.
Yes.
And so, like, you also need to set certain expectations with patients. But I just feel that all of that needs to be well structured, so to speak, and to be able to determine a good infrastructure or build a good infrastructure for all of this. Of course, many our practices need to have the funding to do that. Yeah. And so, going back to your point, like, I know that there have been efforts to try to get the reimbursement. Like, for example, telehealth visits, especially during the peak of the pandemic, we were paid for those. And so, like, what else could perhaps be paid for by payers so that will enable us to have the resources in terms of nurses looking at those tracings, at those transmissions, things like that, and then us discussing what to do next and all of that.
No, I totally agree. I think if the question regarding ethical issues has to do with HIPAA violations, I don't think there's any HIPAA violation here because the source of the data comes from the patient. Yeah. There are some cases where there's active remote monitoring, meaning like an ILR or so forth, that information comes up automatically. The patient's already consented to that. So I don't think there's any ethical issues either way, coming from the patient or coming from the physician. And we have that already in our case, Epic. We already have that process through our system. Another question was, where do you see wearables 5 years from now? That's going to be interesting. I think that's going to be so there's going to be wearables, and then there is quite a few companies coming up with injectables. So how much are you going to be able to get a patient to do so? Hey, I'm going to inject you with something that's going to monitor your heart rate, blood pressure, etc. How up until now it's a wearable, it's a watch, it's a ring. Given the recent COVID pandemic, you talk to somebody about injecting so I could monitor your blood pressure, your heart rate, and so forth. I don't know how much we're going to be able to kind of expand that.
That's a great question. I was smiling when I heard the question because I was thinking in my head, it's not going to even be 5 years. I mean, this field is moving so fast that you could ask me, like, in 2 years, if things are going to be looking very different. from what they're looking now, right? And it's not going to take 5 years for things to look substantially different. I mean, this train is moving fast. Yeah. So that's number one. Number two, I completely agree with you. Like, I think that we will see more and more integration of different vitals, different things that we monitor patients for in a device that's going to become smaller and smaller. So we're going to move more toward like miniature tools that probably will have more things to monitor and to screen for, would be my guess. Now, would patients accept that? Like, going back to your point about the injectable monitors, I don't know. I mean, as we all know, like with external monitors, a lot of people end up getting tired of, wearing a watch or wearing something all the time. And so, like, by having an injectable tool, you bypass all those issues. You forget about it. It becomes like part of you. But I could also see people say, well, no, I don't trust this. What if people are monitoring me for something else? And, you have all those concerns too. And some people don't like invasive things, even though it may be a very simple procedure, like they don't want to undergo that. I mean, I'm really extrapolating from my experience when I have the discussion about ILRs with patients. And yes, the ILRs, I mean, they have gotten much smaller, but I could see these tools becoming even smaller than what the ILRs look like now. I
think that also applies to like CGMs. So there are continuous glucose monitors that are, last for 10 to 15 days, and you inject it on your arm and it sits there for 10, 15 days. But there's also a company that has one that is an injectable underneath the skin and sits there for 6 months. So I think the pathway is going towards these types of, the smaller the better. But the other thing about being smaller is, where do you put it? So eventually that watch would become too big for it. The ring would become too big for it. Yeah. Another question is wearable health devices. Are there any wearable health devices that are a component of digital and mobile health that have the potential to improve heart failure care and outcomes? I think that revolves mostly around remote monitoring.
Yeah, that's a great question. Like, and from my world, I can tell you, because I'm not aware of any like wearable devices that patients can get to monitor their heart failure, except of course for like weight, things like that. But not in terms of like what we can get, for example, from implantable devices. So like for people in the audience who are not electrophysiologists or who do not follow patients with implantable defibrillators or cardiac resynchronization therapy, we have quite a few features now on different devices that can help us assess the fluid status. Even like with some of the devices, respiratory rate, an S3, is there an S3 or not, things like that. So there are, really some interesting and neat features that we are starting to collect more data on that I think can help us monitor patients with heart failure. Yeah,
definitely. I've had a few, maybe 3, maybe actually 4 this year, where I get a phone call from my EP colleague saying, hey, patient so-and-so, I reviewed their device and their conduction. This patient is most probably in worsening heart failure, bring him in. And we bring him in, and truly is, they are. So those remote monitoring devices, I think if they have a defibrillator, a lot of these do have these capabilities. But if I understand correctly the question, the vast majority of heart failure management revolves around blood pressure, activity levels, weight, and a simple questionnaire of symptoms in regards to lower extremity edema or orthopnea or P&D or so forth. Those are those steps that you can take using remote monitoring devices and data to hopefully, prevent readmissions.
Yeah, absolutely.
Next question I have, I know we have a lot of questions. What digital tool would you use for post-CABG atrial fibrillation?
I have not specifically used anything in clinical practice, unless obviously there's a specific situation at hand, but not, monitoring people after they leave the hospital. Obviously in the hospital, they are on telemetry. We're monitoring them very closely the whole time. But after they leave the hospital, our standard of care has not been to implant a loop recorder or to send them out with a monitor or with, to encourage them to get a wearable or anything like that. That said, I actually agree that we need to look at the potential to use an ILR in people. I think there was a study, if I'm not mistaken, I'm working on it, but I think there was a study. Was it presented at the Heart Rhythm Society meeting last year, 2020, I want to say? Anyway, it was a small study, so it did not address the question definitively. But I do think that this is an area where research would be extremely helpful, where you can do perhaps a randomized clinical trial and randomize patients to go out with an ILR versus no, and see if that changes outcomes.
No, very true. I think this is more of a statement. It says, my recommendation is if a wearable comes in with data that is questionable, do not treat atrial fibrillation. Either obtain a 30-day patch monitor or implantable loop recorder and then evaluate the burden and treat accordingly. I think that's what you also said
That's what
earlier.
I do. Yep. That's my practice. That's exactly right.
Perfect. Well, I think we're out of time, but we have had a lot of questions, and this was very, very productive. I really appreciate your attendance today and your presentation and discussion with us today. I think that was very helpful. Dr. Al-Khatib, thank you very much. And I appreciate your presentation today.
Thank you very much. It was fun. Thank you.
Thank you. And ladies and gentlemen, this would be the end of our CV Live session today. Thank you very much for your attendance, and till next month.